Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole here at Tanner, and today we want to move our discussion into what happens when you have a patient come in and they're on chronic opioids. How does this affect your anesthesia plan? How does this affect it from a preoperative standpoint? What is your intraoperative plan going to be? How do you alter things? Is it as simple as giving more opioids? Is it as simple as just adding a few adjuncts in there? What is the goal here to provide the best care to these patients that come in on these chronic opioid medications? And so we really want to go through and discuss that today because, I mean, we all know we have those patients that come in and they're very concerned about how their pain is going to be handled. Is it going to be under control? Because they've suffered through pain for so long. They're on chronic meds. They're anxious. They're worked up. And we want to make sure that we're going to be able to provide the best plan for them. But at the same time, it's often drugs that we don't often see in our routine cases. These patients come in and they're on these high doses of pain medication, and you got to figure out what's the best way to take care of them. So we really felt like it was important to do a discussion on this, just so that when you are presented with this situation, you have some ideas in your head about how to handle it.
Right. And pain can look really different for a lot of different people. You can have people that suffer from nerve pain. They have complex regional pain syndrome. You can have people with fibromyalgia. We know that people that have had cancer can have some long-lasting pain from that, or as simple as just from trauma from the past where they have lasting pain. So it's important to just think about all the different methods or modes that people are going to be feeling pain. And it's not a one-size-fits-all type situation. Oftentimes with these patients that have this chronic pain, they are, taking drugs to manage this pain. You can often see limited mobility in that extremity, or if it's back pain, maybe they're even having difficulty, sitting up all the way. And so you can see functional changes, but many times just to get through the day, they're taking different types of medications just to try to minimize the pain. Often it seems like these patients that are dealing with these painful pathologies, it seems like the medications don't ever do enough. Like they come in and they're still feeling pain. And then they have this long laundry list of medications that they're using to try to mediate that pain. But it still doesn't seem like it's, always doing, great for the patient. Oftentimes they're still feeling that pain, even when they come to us on the day of surgery. I feel like most of the time we deal with opioids, we deal with them all the time on a daily basis. The question here is, how do you manage somebody who's already has the baseline of opioid therapy, or maybe even other medications that they're using on a daily basis? So I think before we go through this talk, it's really important that you would go over to our pain pathway presentation. There we talk about how the signals will travel through the body, how those inflammatory mediators will then turn into the pain signals that our brain realizes. And so we're going to assume that you've already listened to that. You're up to speed on that. When we start talking about the different strategies, it's important that you know that. Also, we talk about different therapies that we can use, opioid adjuncts, in another discussion as well. That's going to be another discussion that's important for you to listen to as we simply just kind of mention those things here. That's not going to be the main part of this discussion. We're just going to mention those as if you've already familiarized yourself with those things.
When it actually comes to the chronic pain medications that these patients are on, there can be a wide variety of medications. The most common first line for anything that starts, whether it be like an acute injury that then is going to progress into a chronic pain, or maybe they have chronic migraines or headaches. Oftentimes we see these patients either on Tylenol, so acetaminophen, or they're going to be on NSAIDs such as ibuprofen. And oftentimes, these patients are going to be on these maybe just over the counter. They're just taking this to kind of manage their pain. And then it escalates enough where they're going to have to be on some more heavy hitting pain medications. But we often see that patients are chronically taking these things. And so, as we all know, NSAIDs can cause kidney injury. So just be careful of monitoring their kidney status if they are on chronic NSAIDs, as well as the Tylenol can cause some damage to the liver. So we should be keeping an eye on that as well. But again, here, the whole goal with the NSAIDs especially is just to decrease the amount of prostaglandins that are circulating. And if you've gone through our pain pathway episode, you'll understand how that prevents really the first step in the pain pathway initiating. Other medications that these patients can often be on are anti-epileptic medications or drugs such as gabapentin or pregabalin. And these are often used in chronic neuropathic patients or neuropathic pain patients. The most common side effects from these drugs can be peripheral edema or dizziness. And again, these are more used as adjunct therapy for other chronic pain conditions, but especially in the neuropathic pain, these are really the heavy hitters. Antidepressants have been increased in their use as well, especially TCAs, tricyclic antidepressants, as well as SNRIs, selective serotonin and norepinephrine reuptake inhibitors. And both of these, again, are really used in the neuropathic pain management. If you've gone through our pain pathway when we discuss the body's natural pathways that it sends to inhibit pain responses, you'll understand why these medications make sense. So again, as Tanner mentioned, if you haven't gone through that episode yet, I highly encourage you to go back and do so before we go through some of these medications. With those TCA medications, they have a really high efficacy in protecting against this neuropathic pain, but they do have some side effects. Side effects include if a patient already has a pre-existing heart block, it may increase the severity of that, as well as a dry mouth and urinary retention. Whereas the SNRIs, they have less side effects, but again, they have less efficacy in the reducing that pain.
As we get a little farther into this discussion, we're going to talk about different side effects or different symptoms that you're going to want to monitor for. We'll talk about withdrawal here in a little bit, something that you'll want to pay attention to, the signs and symptoms of that. I would say here too, if your patient is on any of these medications for this neurologic pain, think about also serotonin syndrome, especially with these SNRIs. And when we're looking at these different symptoms that the patient may be exhibiting either intraoperatively or postoperatively, just something also to keep on your radar, as always, whenever you see this in your patient's med list. But I thought I'd just mention that there. The next thing we want to talk about is the opioid use for patients that come in that are dependent on opioids. So since the early 2000s, opioid use for non-cancer related pain has dramatically increased. And with that, we've seen the number of drug overdose related deaths also increase. Chronic opioid efficacy compared to non-opioid interventions are pretty controversial when dealing with non-cancer related pain. There's just a ton of patients that, again, are on these chronic opioid medications, and this discussion we'll save for another time. But it's just important to know that this is something that we are going to see very frequently in the hospital setting. If you're practicing, you do see this frequently in the hospital setting. It's almost something that I feel like whenever I see that in their med history, it's just like, like another Medicaid. It's like seeing them on like atorvastatin almost. It feels like when I see Lipitor, I'm like, oh yeah, whatever. And then I see that they're on hydrocodone and I'm like, okay, yeah, whatever. And that's just unfortunate because you do see this just all the time. We'll link this article here. It's by Hyder and Rathmel. It says that Americans consume over 80% of the world's supply of the opioids, such as oxycodone and hydrocodone. I think that's just pretty remarkable. And we just wanted to mention that here when we're talking about how we need to tailor our anesthetic plan. This really is something that we encounter all the time and important to consider. There's also long-acting opioids such as methadone or controlled release morphine that are prescribed in order to maintain kind of more constant level of pain control. If you have short-acting opioids prescribed such as hydrocodone, then obviously this when you're managing your patient's pain after a procedure, there's going to be fluctuations. It's not just a consistent, steady state. So oftentimes you'll see these patients on methadone as well.
sometimes these fluctuations, another thing to consider is they can actually result in a misuse of medications by the patient simply because they're looking for better pain control, and maybe they were out and about, didn't have their meds with them, and now they're, kind of behind the eight ball as far as managing their pain. So they take an extra, dose at that point. So there's just really kind of some problems with these shorter acting opioids for patients who are managing it themselves. And so usually you can see these patients that are on long-term pain therapy on something like the methadone, and they probably still have some short-acting opioids just for breakthrough pain. But again, this is something that you'll probably see them on. We should mention here that methadone is going to be a complete agonist with your opioid receptors. You can also see patients that will be on buprenorphine, and that's something that we'll talk about here in a little bit, but that's going to be a partial agonist. And this is going to be a little bit different when we talk about how we're going to manage these intraoperatively. I will say, too, that there's some conflicting literature and conflicting expert opinion about how to manage this. So we're not going to tell you definitively this is exactly what you should do every single time, but we're going to give you hopefully enough tools that you can make an informed decision.
Right. Most of the opioid medications that we deal with on a daily basis are full agonist, whereas some of these medications, as Tanner mentioned, can be not only just partial opioid agonists, but they're also opioid agonists / antagonists. And what we mean by this is, if you remember, there are several opioid receptors in the body. Some of the main ones are going to be the mu receptor, the delta receptor, and the kappa receptor. And so these medications that are partial agonist antagonists, what that means is that they may agonize or, bind correctly to the receptor at some of these. So like the delta receptor, but at the same time, they're going to be an antagonist to a different opioid receptor, such as the mu receptor. And so as a result, they're going to be agonizing some of these and antagonizing others. And we're going to see here in a couple minutes why that poses a problem. And that's because if they're antagonizing one of the receptors, and then I give another opioid that's supposed to agonize that receptor, well, they're going to compete with each other. And they're going to not have the same response that we would typically see, such as if I were to give the patient fentanyl in a case and they're on a medication that is a partial antagonist, it's going to hinder the result of that fentanyl that I give. And that can pose a big problem. So that's why it's really important that you pay attention if a patient is on a partial agonist, antagonist, opioid medication, because it can have a really big, significant impact on your pain management and control during a case. But we'll get into that here shortly.
Aside from opioid interventions, there are a couple of things that we, are well aware of that patients may be, doing to manage their pain. Oftentimes you'll see them going to get steroid injections. They're even getting nerve blocks or having spinal cord stimulators. These are all different modalities or different therapies that can be somewhat helpful. But for this presentation, we want to stick with the patients who are coming in that are on chronic opioids. We could get into kind of how those other therapies could interfere with your anesthetic plan. It's not really going to make that big of a difference. But here, what we want to, focus most of our time on is these patients that are coming in that have a tolerance, have a therapy at home with opioids. Now, when we're getting to the preoperative setting, how are we going to manage these patients? It's important to know that these patients on chronic opioid therapies are going to be prone to having higher postoperative pain. And with this, they're going to have a longer time before they have actual relief from the surgery compared to patients that are not on chronic opioid therapy. And again, we'll link this article. This is by Bordy in 2018, wrote this article. It makes total sense. And when you're seeing these patients in the perioperative setting, you'll notice this. One, like I said at the very beginning, oftentimes these patients who have these chronic pain pathologies, it's not like the medications they're taking at home typically remove it completely. So they're still having this underlying pain usually. And I'm not speaking for everybody, obviously. I'm not going to speak in absolutes. But more often than not, that's what I typically see. They're coming in, they're, every time they move in bed, they're in pain, or they have this chronic back pain, or they just live with this underlying pain, even though they're taking these medications or using these therapies to try to manage it. So again, they're going to typically have higher postoperative pain. And part of that, we'll talk about this, is simply because of how the receptors are acting, being saturated, and the tolerance that comes with being on chronic opioid therapy.
So this is obvious, but with any type of anesthetic that we're going to do, with any type of patient we're going to take care of, it's highly important to review their medical history in order to determine what is the best individualized anesthetic plan that we can give these patients. The things especially that we should be looking at, which go hand in hand with what we want to talk about here, is that you should look at, well, does the patient have any pre-existing chronic pain? And if they do, what type and severity of pain is it? Is it neuropathic? Is it from a trauma? Is it cancer-related pain, et cetera? And that will kind of tell you and give you an idea of what kind of management you're going to be doing during your procedure to manage that pain. Is the pain connected to something that we're going to be doing the surgery for today? Is that surgery that we're doing going to correct what is causing their pain, or is their pain something different and their pain's going to continue to last in the postoperative setting after we do this procedure? Are they on any adjunctive therapy to limit their pain? What are the current pain meds that they're on? Are they on long-term pain meds? These are all things that you should be looking at. What's especially true, as we mentioned earlier, is you need to figure out, well, if they are on long-term pain medications, are they full agonist? Are they partial agonist antagonist? What kind of medication and class are they using to manage their pain? So if a patient is on a chronic long-acting opioid, such as methadone, it's important that the dose should be continued all the way throughout the perioperative period. The same is true for other pain medications, such as anticonvulsants, antidepressants, all the ones that we talked about earlier. But the last thing we want to do is to stop their medication a day or two before surgery, because a lot of these medications that they're on, we have them stop, a few days before the procedure, we stop the day of, et cetera. This is not one that you want to do that for. You want them to come into the pre-op setting with their baseline level of pain control that they had. And so the last thing you want to do is have them stop it. They come in, they already now are behind the 8 ball, they have their pain escalating. And not only do you have to play catch up with managing their pain from a baseline standpoint, but then you got to manage them when they go back into the intraoperative setting, and you're already behind at this point. So you really want to make sure that if they're on a full agonist opioid pain medication, such as methadone, you just continue that all the way through. If they did not take their daily dose the morning of the procedure, give them an equivalent opioid dose in the preoperative setting, preferably 1 to 2 hours ahead of time. Get back on top of that pain medication before you even take them back intraoperatively. And so again, this doesn't have to be the same exact medication. So if they're on methadone, you don't necessarily have to give them methadone preoperatively if they didn't take it in the last 12, 24 hours, but make sure that you're giving an equal potent dose of another opioid that would manage that pain equally. So if a patient comes in and they have, let's say, a transdermal fentanyl patch, so make sure that they keep that patch on. Again, the whole goal here, because fentanyl is a full agonist, full opioid agonist, you want to just continue that all the way through. So we don't want to mess with that patch at all. Just maintain that steady baseline level of pain management. If the patch is removed somehow, either put on a new patch or you can start a fentanyl drip. Just make sure you're giving an equivalent baseline dose. It's kind of like, if a patient comes in and they're insulin dependent, we might change their insulin dose a little bit, obviously, in the preoperative setting, just because we're going to be fasting. But we also don't want to completely shut it down altogether. You're going to still give some baseline basal dose of that insulin. The same thing is true here. You don't want to just stop that baseline pain control. You don't want to be behind the 8 ball. You want to just maintain that steady state, and then you're going to add stuff once we get to the intraoperative setting.
Right. And this is, like I said, this is not like a one size fits all solution, because everybody's pain management is going to be different and individualized. And so it's important that you clue in your resources here. Hopefully, if this is an elective procedure, you have some sort of pre-anesthesia clinic that's able to discuss, the plan with these patients several days before that we're actually doing a procedure. Or even if this is something that needs to be more involved, several weeks in advance. And so this is the other thing I would just tell you. If a patient's on like buprenorphine, for example, there's conflicting literature. Some will say that you continue this through the procedures. Most of the literature that we've seen says if it's going to be like a minimally invasive, not very, high pain procedure, like an endoscopy, procedure, then you just continue that medication. There's some conflicting literature about if it's going to be a more involved case, whether you would tailor them off of this medication or you'd continue it through the day of surgery. What I would tell you is you need to connect with the clinic who's prescribing this, you or somebody on your team. Again, if this is an elective procedure, to communicate with them and develop a plan for how you're going to manage this patient intraoperatively. And again, like Cole mentioned, it's pretty clear that with methadone, you typically keep that going through the day of the procedure. You're trying to keep as many things as standard as possible. But if you are needing to change up their regimen, again, for someone who, like, for example, would be taking the buprenorphine, then this would be something, again, that you want to connect with as many resources as possible, clue the patient in, have the patient be part of the conversation with the clinic who's prescribing it. That way you can all be on the same page as you move through the preoperative setting and into the actual procedure. This is just going to make these conversations in pre-op a lot better, and it's going to set your patient up better actually for the procedure. Obviously, if you've needed some time, greater than 5 days or so, to actually wean them off of these medications.
And really, in the preoperative environment, our main goal when we come in there is to comfort these patients, because oftentimes they're going to come in and they're going to be very anxious and worked up, especially with how their pain is going to be managed, because these patients have dealt with pain for a long time. It comes in many shapes and forms. It could be all physical. It could be a lot of mental. It could be a mixture of both. There's a lot of psychological effects from being in chronic pain. And so when these patients come in and they're knowing that they're about ready to go through a painful surgical experience, it works them up. And more times than not, they're pretty anxious. And so our job as anesthesia providers is not only to do the case and get them through it, but it's also to comfort them, be a reassuring voice for them. And so, especially when I take care of these patients in the preoperative setting, my main goal is to address their pain management right off the bat. Tell them, you know what, my goal here is not only to successfully get you through this case, but I want to get you through it as comfortable as possible. But at the same time, it's really important that you talk about realistic pain management goals with them. More times than not, you're not going to have them 100% comfortable when they wake up. And it's something that we need to see how they wake up and manage their pain when they do so. That doesn't mean we're not going to try to get them as comfortable as possible before they wake up, but they need to be under the understanding of, we're going to do X, Y, and Z to manage your pain intraoperatively. When you wake up, if you have any pain, and you're probably going to have some level of pain, this is what we're going to do at that point. And if you have that expectation ahead of time, you let them know that there's already a plan in place, it really eases their anxiety level. Again, once you talk through all this with them, then you can start giving them some Versed, other anti-anxiety medications, etc. I always wait until after I've discussed it all with them before we start working in those medications. But it's really important that you build up that positive rapport with the patient right off the bat. Explain to them what you're going to do for them to manage their pain. And that can really go a long way.
Yeah, I couldn't agree more. I had a patient actually last week that had this exact scenario. We were doing a big back case and was chronically on different opioid management therapies. And I think going in there, like you said, Cole, like a lot of times there's a psychological component of being in pain for so long and then knowing that you're about to go through something that's even more painful. And I thought was really helpful during that conversation was including the family members and just talking to them and telling the patient, like, you're not new to pain. You live in pain. And so I'm not going to, tell you that I'm going to be able to take all that away. And I want to be very realistic with what we're expecting from this procedure. I'm also going to tell you my plan, because this is going to be challenging since you've had this opioid therapy for so long. There are some challenges that come along with that. But here's my plan to try to attack it from as many different angles as possible. And I told them, when you wake up, I do expect that you'll still feel some discomfort simply because you are undergoing a major surgery. But my job is to first and foremost keep you safe. And then secondly, I'm also going to try to attack the pain pathways from as many different angles as possible. And I think it helps for several different reasons, but also they just know that you're taking this seriously and that you're taking the time to personalize your plan. And they know that that they feel pain and that they are in this situation. And I think just communicating that up front for me was really helpful. When she woke up,
She said she was feeling a little bit of discomfort. And, I just was able to talk to her. I was like, we expected a little bit of that. This is all the things that we did. You did great. You're safe. Went through the procedure just fine. And we still, were able to manage her pain with some other things. But I think just her knowing that I was on her team, like I'm trying to do as much as I can to try to alleviate this, but also setting those realistic expectations for, what post-op is going to actually look like for him. So I couldn't agree more, Cole. I think that preoperative communication, like the power of suggestion, right? Like how much of communicating to them up front really does hold its weight in the recovery. The other thing that I think we should really talk about here is when we're talking about the intraoperative component. And so, there's no one best plan for what you'll do every single time for these patients. But again, try to individualize it for this specific patient and then try to pull in as many different adjuncts and different things that you can do to try to manage these patients. Keep in mind that chronic opioid users will have a receptor downregulation and tolerance to the medications, which means they typically will require about 30 to even up to 100% increase in opioid dosing. We took that right from the Bordy article that we mentioned earlier. You want to avoid opioid antagonists and agonist antagonists because these can precipitate acute withdrawal. And so if you have somebody who, again, has the tolerance, you want to avoid these medications as you can get into withdrawal. Just quickly, I'll mention a few real hallmark signs of withdrawal: nausea, vomiting, which can be attributed to our anesthetic anyways. So that's kind of difficult to pay attention to or try to, work out through your different differentials. Muscle aches, body aches, if they are really lethargic, they have digestive distress, indigestion. Anxiety is a really common one. Fever, chills, sweating, difficulty concentrating. These are all things that you can typically see with withdrawal. Again, if they're under general anesthesia, some of these can be confusing and trying to figure out what this is attributing to, but something just to keep on your radar anytime you're taking care of a patient who has a history of opioid use.
So as Tanner alluded to, it's really important that we have a multimodal approach to our pain management here. Again, they're going to have the receptors are going to be downregulated. They're going to have a very big tolerance development, especially if they're on a full opioid agonist such as methadone. They're going to require a lot more opioid management, and the opioids that you give them are going to have a diminished effect. And so as a result, it's really important that you bring in this multimodal approach. And so what we mean by that, now, if you haven't listened to one of our just recent episodes, we went through opioid adjuncts and all the different therapy that you can do from an adjunctive standpoint. But some of the things that we mentioned was ketamine, Precedex, lidocaine drips, local anesthetics, et cetera. There's a lot of different options we have available to minimize the amount of opioids that you're doing during a case, or in this situation, you're going to be giving it on top of the opioids that you're doing during a case to make sure that we're covering the full scope of pain management that we need to. And so feel free, if you haven't checked out that episode, go check out our opioid adjunct presentation, and that'll give you a lot more information. But another thing that we really need to focus on here is if regional anesthesia is an option, I highly recommend that you look at regional anesthesia. It's very, very useful. All across literature is recommending doing regional anesthesia when it's available. So this can be, peripheral nerve blocks. So if you're going to have a shoulder procedure, you're really going to want to do an interscalene block. If you're doing something on the lower leg, do a neuraxial anesthesia. So be doing a spinal. If an epidural is an option, do an epidural. Especially here, try to use the local anesthetic that you do for these blocks. If you can use a longer acting regional anesthetic, such as Exparel, this is recommended, or the use of a continuous catheter that you can put in and continually inject that local anesthetic into that space to provide the analgesic properties that we need to in the postoperative setting for several days afterwards. Keep in mind, though, that while this may be blocking their pain from the procedure, if it's not a specific surgery that's going to target what their chronic pain is from, or even if it is targeting that chronic pain, if they've been on chronic pain medications, you can't just simply stop those medications because they're not in any pain due to the local anesthetic from that regional anesthesia. Underneath, they can be starting to have withdrawal effects if you were to stop that baseline opioid dose. So make sure that you're keeping that medication full on in the background. And again, if this is a procedure that is supposed to help correct one of their main issues that's causing their chronic pain, then you want to start to consult with their pain physician about actually titrating down their chronic opioid medications after the procedure, after that post-operative setting is done with. You can move into that then. But your job is to make sure you maintain that baseline, don't allow withdrawal to build up. But also you want to be providing as much pain control as you can. So that regional anesthetic is such a good option that if you can do that, I highly recommend that you do that.
The last part of the perioperative plan, obviously, is the post-operative period. So how are we going to manage these patients post-operatively? I think it really does go back to the preoperative conversation and managing expectations. And again, also starting these therapies early, these multimodal therapies, so that hopefully when we get to this point, we are already ahead of the game. But it's important that we also, consider some other things that we can do at this point. So like Cole mentioned, longer acting regional anesthetics, or if you're using a catheter that you leave in place for a regional block, is going to be really, really helpful. If there's not the option to do that, you can give them a PCA pump. Make sure you set the pump to have continuous dose that's equivalent to their baseline dose that they usually take. Then there should also be the ability to treat breakthrough pain, so that you would set up an additional dose there for the patient if they're going to have, breakthrough pain at that point. It's also important that you get the patients back on their baseline medications as soon as they're able to take them. In anesthesia, we're not trying to fix these long acting problems. We're just trying to get them safely and comfortably through procedures. So like Cole mentioned at the very beginning, the less we can change with their therapy up front, the better. And then the faster we can get them back to their therapy also is going to be better, that we disrupt as little as possible for their typical pain management. The other thing that we want to think about is, and this really isn't going to be so much with us in the hospital setting, but it's something to communicate with the patient and also, initiate conversations with those who will be managing the patient. But if they are taking more opioids to treat pain that is caused by the actual procedure, how are we going to wean them back off of those additional opioids back to their, baseline regimen? So this is something that if they are, seeing a pain clinic, if they are seeing a pain specialist, this is important that, like we said before, you're communicating with them preoperatively to develop a plan, but it's also important that you're handing back off to those services afterwards, so that they can get back on their scheduled doses, get back on their scheduled plan. If something needs to change because either having more pain after a procedure, ideally, hopefully they're having less pain, if we're treating that procedure. Obviously, there's a million different reasons these patients are undergoing surgery. And so there's just a lot of situations that can arise here. But communication with the people who are experts in that pain service, and we would think of ourselves as pain experts, but we're pain experts. Typically, you think of it in a perioperative setting. And so getting that handoff back to somebody who's going to be able to long-term help them with their therapies is really important. The last thing that I'll say here, especially when you're talking about patients who are on methadone or patients who are on buprenorphine, these different types of, longer acting medications, like we said, there is conflicting literature out there as far as the management. I would challenge you to go to, your protocol sheet, protocol binder, try to find what your hospital or your institution's protocol is for the situation. Again, we found conflicting things, whether it was expert opinion or actual algorithms that we read through. But it's just important that you're familiar with those things, familiar with what your hospital will do or your anesthesia group will do with these patients. That way, when it does show up, again, you're kind of ahead of the game. Hopefully, again, you're working with, a pre-anesthesia clinic who is going to start these conversations. But again, I think it's just important that we are aware and understand how we can manage these patients who are on long-term opioid therapy.